bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. And for this episode, we'd also like to thank Icaria, now part of Mallinckrodt Pharmaceuticals, for supporting our webinar program, and in particular to this three-part series on patient safety. Icaria has been a supporter of the CAFC conference for the last couple of years, and we look forward to welcoming them and their colleagues from Mallinckrodt Pharmaceuticals to the 2015 CAFC annual conference in Quebec City, where they'll be hosting a breakfast session where they're going to invite delegates to continue this dialogue around patient safety. So thanks to Icaria and Mallinckrodt Pharmaceuticals. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Patient Safety After 15 Years, Disappointments, Successes, and What's on the Horizon. Patient safety, and in particular pediatric patient safety, has been one of the key programs at CAFC for many years. We've done many projects in this area around medication reconciliation, opioid safety, and many other programs. We have a pediatric patient safety collaborative that has a monthly webinar. For those who don't know, it's the fourth Friday of the month at 11 a.m., except this month because we invited the patient safety collaborative to this webinar. Today's topic, however, has come from conversations that we had with some colleagues that commented that 10 or 15 years ago there was so much patient safety activity across the sector when it was all new and exciting, and organizations creating positions and departments to drive a patient safety agenda within organizations. And I think all that activity really gave the sense that we were really making headway in this issue. And now it's almost like almost seems like a general feeling that some people think maybe we nailed it or are in the process of nailing that whole patient safety issue, and it doesn't really seem so front and center as it once was, or people get the sense that it's being taken care of by those patient safety departments that were all created. So it just doesn't seem like it's right top of mind for your average clinician in pediatric healthcare today. But today we're going to hear from a couple of great speakers who are going to take us back on that 15-year journey and see where we've ended up and where we can look back and maybe pat ourselves on the back, and maybe even a few spots where we haven't achieved what we thought we were going to achieve or thought we did achieve. So it's going to be a great topic. But before it's my pleasure to introduce two great speakers, long history with CAFC and with patient safety in general, presenting at conferences going back to 2008 and other great projects that they've done with us over the years. First off, we'll be hearing from Dr. Kaveh Shojania, who has a long history of internships and residencies at some of the leading patient safety or leading hospitals that have done patient safety research around the world. He came to University of Ottawa first, and then down to the University of Toronto, where he is still a general internist at Sunnybrook Health Sciences Centre, and co-leads, along with Professor Ross Baker, the master's degree in quality improvement and patient safety at the University of Toronto's Institute for Health Policy Management and Evaluation. And he has a long list and bio that you can find more detail on our Knowledge Exchange Network. And following Dr. Shojania, we'll be hearing from Dr. Trey Coffey, who was inspired by her residency at Seattle Children's Hospital and brought this passion for patient safety to the Hospital for Sick Children in Toronto and their division of pediatric medicine back in 2005. Dr. Coffey has co-chaired the division's quality and morbidity and mortality committees and completed the University of Toronto Certificate in Quality and Safety in 2009, and her research interests include medication reconciliation, disclosure of adverse events, teamwork and communication, and lots of other great patient safety focused topics. So, and again, more information on the CAFC Knowledge Exchange Network. So it's my pleasure to hand the virtual podium over to Dr. Kaveh Shojania.
Thanks very much, Doug. I'm just going to get back to the right part at the beginning of the presentation. I guess I'll just say that I understand why you said that people may have the impression that safety has sort of disappeared, and part of me is glad about that in some ways, but I don't think it's because we've hit it out of the ballpark, and there probably isn't a lot of back padding going on among experts in patient safety. But the reason part of me is glad that we don't hear as much about safety is that I think the people who originally wrote the IOM report to err as human 15 years ago, we're really trying to grab people's attention after years of working unsuccessfully in quality improvement in general, and people getting tired of hearing about, over-treatment, under-treatment, guidelines. They're not exactly the sexiest topics in the world. And so when they published the report announcing that 44,000 to 98,000 patients were being killed every year from medical error in hospitals alone, that succeeded in grabbing people's attention. And they followed that report up with Crossing the Quality Chasm, where they emphasized that safety is just one of 6 dimensions of quality. And I think what's happened in the first 5 years after the IOM report, I think everybody tried to present any quality problem as a safety problem, but then eventually people became more comfortable with talking about other dimensions of quality, and so now you'll hear a lot about patient-centeredness, of course, about efficiency. That's always on people's agenda. Equity, I think eliminating waste and so on. So part of me is glad that we don't hear as much about safety, because I think the other dimensions of quality are really important, but it is not the case that we've really hit it out of the ballpark. There have been a few successes, and of course the title is Disappointment, Successes, and What's on the Horizon for this talk. I'll try not to dwell on the disappointments and make this too much of a downer, and I will just mention that actually I've had the honor of sitting on a panel led by the National Patient Safety Foundation. I'm co-chairing it with Don Berwick, who everyone will know from his days at IHI, where we're looking at what's happened in the field over the past 15 years, and so I've had a chance to think about this a lot. I'll just, in terms of the disappointments, I basically limited them to 2 slides, and this one and the next one. And it really just summarizes the idea that I think that in patient safety there's been 2 basic approaches. One of them, the systems approach, was the one we first heard about by the authors of the IOM report. It was really calling for emulating the approaches to safety in aviation and other high-risk industries. It was the systems approach, the Swiss cheese model. We've all heard about these things before. It involved a really high-profile incident reporting and aviation-style error analysis, and applying the principles from cognitive psychology, ergonomics, and operations research. And then on the other side, which actually I and some colleagues were initially most interested in, was a more of a clinical research approach, which was that, we're good at giving medications and implementing guidelines and so on, and so maybe if we, instead of talking about sort of vague principles from aviation, we focused on things like central line infections and venous thromboembolism and, strangulations with IV tubing and so on, and identify practices that reduce these events, and then develop strategies for effective implementation, will probably make more progress. Well, those approaches are, by the way, are not mutually exclusive, but we have definitely seen the limits of both of these approaches in the past 15 years. I would say, in the interest of keeping this somewhat interesting, so it's not a snooze, I'll come right out and say something blunt, and that I think incident reporting is the single biggest waste of time in the last 15 years in patient safety. It's also probably the most mistranslated intervention from aviation. I think that what people in healthcare have done with incident reporting is focus on pie charts and trend data, and thinking about the fact that the incident reporting is like almost an end in itself. It's not at all how it works in aviation. I'm still not sure whether we would get as much out of incident reporting as they have in aviation, but in any case, in aviation, a couple of things that really differentiate it from what we do in healthcare are that, first of all, there's a centralized agency that is independent from the airline or whoever it was that was crashing that is responsible for this. Also, the inquiry is the process of interest, not the actual reporting. And I think in aviation there's much more of a culture of constantly inquiring into how to make things better or how things could go wrong, whereas in healthcare what we've really done is just focus on capturing all these events in a database and then producing pie charts and trend data. And as I've written on the slide, I mean, the numbers speak to reporting behavior, not event rates. We can't have our cake and eat it too. We can't claim that more incidents means better culture, but then when we have our quarterly reports with our board say that, oh, we haven't had many incidents, so the hospital must be doing fine. You can't say that more events means better culture, but then on the other hand saying we want less events because that'll mean we're safer. as I was mentioning too, in aviation, the most important part about incident reporting is the actual investigations, which we tend to refer to as root cause analyses. And in healthcare, I think anyone who's done this for a while will have to admit that most root cause analyses produce very superficial recommendations. Send a memo to people, educate people. The deeper recommendations are either not made or they're not pursued. And I think that's also understandable. Remember, in aviation, they have a centralized agency that's working across all of these airlines and so on, and they have people with core expertise. It's a little crazy for us to think that we can just throw together a multidisciplinary committee at a local hospital and solve deep problems about the way healthcare is delivered. I mean, not surprisingly, that's not something people relish doing, and when they do it, they don't necessarily succeed. For the clinical research approach, the advantage is supposed to be that instead of reaching for the moon, we're going to just sort of, identify some common, concrete complications or hazards of healthcare and identify evidence-based strategies for preventing them: venous thromboembolism, postoperative complications, central line infections. The problem with this approach has turned out to be that the low-hanging fruit, so-called, are not so low-hanging in a lot of cases. It takes a lot more effort to implement them, and frankly, when we finally get the fruit, the juice isn't necessarily worth the squeeze. Some of these targets are so narrow, and even something as admirable as the central line bundle, which is one of the most famous things in healthcare. I mean, yes, of course, I know it's bad when somebody has a central line infection, but realistically, when you look at the whole field of patient safety, a central line infection is like a grain of rice. It's like such a small portion of all the harm that patients can experience that to sort of say that we really accomplished something with that, it's a little hard to justify. And for someone, I don't know as much about pediatrics, but in adults, there's emerging literature, for instance, at venous thromboembolism prophylaxis, which actually I originally championed as one of the most important patient safety interventions, and colleagues of mine at Sunnybrook are world experts in it. If anything, we've been over-prophylaxing patients, and tons of low-risk patients who would never have a clot are now all getting heparin. And so I think that this idea that there would be low-hanging fruit with some of these more clinically oriented patient safety problems has turned out to be misleading. And the evidence supporting specific interventions can change unexpectedly. So to give a concrete example, unfortunately from adults, but in the second most highly rated patient safety intervention when we did this large evidence report for the Agency for Healthcare Research and Quality after the IOM report came out, was perioperative beta blockers to reduce cardiac complications for general surgery. There was, at the time, 6 small randomized trials all showing benefits, which compared to other interventions in patient safety was a huge amount of evidence, but then a mega trial came out, actually led by Canadian researchers at McMaster and published in Lancet, which showed that not only did it not work, but it might be killing patients. And actually, we know in clinical research that that happens, and it shouldn't be any surprise that it happens in patient safety from time to time. To give a pediatric example, there's been so much mixed evidence on the benefits of rapid response teams. In fact, there was actually a wonderful article from Stollery Children's that showed that even though they had never implemented a medical emergency team or rapid response team, they actually saw reductions in mortality just from secular trends at the same time periods as the published evidence had shown that there was a reduction. And when studies had been published that showed no improvement, they showed no improvement in their data. So that's just, that may sound a bit academic, but it just shows you that what Stollery Children's Hospital showed was that they had the same benefits seen for the studies of rapid response teams at the time of those studies, even though they never had a rapid response team. And when studies came out that showed no benefit, they had no changes in mortality at their institution either. So I think a lot of times the evidence, just like in the rest of medicine, can change. So as I said, I've been thinking a lot about this with the NPSF and with Don Berwick and some other colleagues as part of this expert panel looking at where we are 15 years later. And a colleague, Sanjay Saint, who's a general internist at the University of Michigan and has done a lot of work on infection control and patient safety, quoted Carl Weick, who some of you may recognize because he did a lot of work on high reliability organization and is widely quoted in amongst organizations in healthcare that are interested in sense making and high reliability organizations. And Weick, who's a professor at the business school at the University of Michigan, said that on the far side of complexity lies profound simplicity. And my colleague summarized his view, and actually he puts it I didn't quote it here, but there's a nice blog piece from just a couple of years ago where he explains this view. But the basic idea is that knowledge often moves in three phases, beginning with a superficial simplicity, then a confusing complexity as underlying previously unidentified problems surface, and then finally we end up on the far side of complexity with a profound simplicity. And how I would relate that, or why I think that that's very apt for patient safety, is that we started with the superficial simplicity, which I think was emulating other high-risk industries, talking about incident reporting, the quote-unquote systems approach, checklists. Then there was confusing complexity as we tried addressing multiple safety targets, encountered multiple implementation problems, changing evidence, and some of the problems that I mentioned. And finally, we end up sort of back where we started with profound, but more profound understanding of what it means to call for teamwork, communication, and cultural changes. And I'm going to try to illustrate that with an example involving checklists. But just to emphasize again, what I'm trying to say is that I think the pendulum has sort of swung, as we often see in fields and in the rest of life. There was an initial enthusiasm for emulating aviation, incident reporting, human factors engineering, culture, and teamwork. Then the pendulum swung towards specific complications of care, like the central line bundle, surgical checklists, VTE prevention. Many did not pan out, or the targeted very narrow problems that I mentioned. And now we're seeing the pendulum swinging back more towards teamwork and communication and culture, but with more evidence to support specific ways of accomplishing these goals. So the checklist is, I think, one of the most famous things in patient safety, thanks to Atul Gawande. He wrote about it in the New Yorker, and of course he published the original New England Journal of Medicine study about the World Health Organization's safe surgery checklist, and then also, of course, Peter Pronevost's work with the central line, which is bundle, which is often regarded as a checklist, even though he himself has often pointed out that it's not just the checklist. Well, after years of hearing about the checklist and how wonderful it was, David Urbach and colleagues here in Toronto used the opportunity provided by the legislation that had mandated use of the checklist in Ontario, and then, of course, the opportunity provided by the databases at ISIS to look at outcomes in Ontario before and after adoption of the checklist. And they didn't just use the data that they had from all the hospitals' discharge diagnoses and complications. They also specifically contacted the hospitals to find out when they implemented the checklist and find out when they achieved high compliance. And basically, across 100,000 surgeries before adoption and roughly 100,000 after, there was no significant change in mortality or complications. So what's the interpretation of the study? Well, mandating a surgical checklist achieved no impact. There was actually a slight trend towards possibly some improvements in mortality in cardiac and neurosurgery. Now, some people asked the question when the study came out, why did they just study 3 months before and after implementation? Well, the answer is that if use of the checklist were all that mattered, 3 months at a high compliance should be enough. Well, many people would say that that's not the whole intervention. The real changes in communication need to occur. It's not a tick box exercise. Well, it's worth pointing out actually that many checklists are a tick box exercise. Like when I go grocery shopping, I'm not expecting to have some shared mental model with either my wife or with the grocer clerk. I'm expecting to just look at the checklist and tick off the items that I need. And there are examples of checklists in healthcare like that, like order sets. But fine, maybe sometimes we want a checklist that does more than just the items on the checklist, and we want some teamwork and communication to come out of it. Though again, interestingly, this is actually not how checklists work in aviation. In aviation, checklists really are checklists. They do teamwork totally separately, and they do it far more intensely than we ever do in healthcare. So this is actually another interesting example of the simple narrative or the simple view of how to emulate aviation has actually been overly simplified. But in any case, moving back to the surgical checklist, let's say that there is something to the checklist and it's really not just a tick box exercise, you need to implement it more intensely and have teamwork and communication. Well, this recent study from Michigan did that, and actually they used the same approach that Pronevost's group had used for the central line bundle, and in fact that study, some of you may know, also took place in Michigan. And they used a checklist that focused on compliance with 6 specific measures that actually the surgical complication improvement project, it's basically NISQIP. It's like the most famous and clinically validated approach to proving surgery outcomes these days. So this was a very important set of items. Also, they were very concrete items about antibiotic selection and timing, discontinuation of prophylactic antibiotics, hair removal, and so on. And importantly, again, they used CUSP, the Comprehensive Unit-Based Safety Program, which was the same approach that achieved success with the central line bundle. And what they found in this next slide, it shows hospitals that were control hospitals, this slide just shows before and after, but they also have data that I haven't shown here that shows the control sites that were other hospitals that didn't participate in this intervention. But basically, there was no improvement in any complication, in any wound complications, or in 30-day mortality. So what's the conclusion? Well, the Ontario study is really a you get what you pay for. If you mandate checklists, you're going to get superficial implementation, and surprise, surprise, you don't get much out of it. It's not as easy to dismiss this Michigan study, though, as an implementation problem. This was a very earnest effort, and again, the way they implemented it was exactly the way that you're supposed to implement it. They emphasized the debrief, they emphasized the communication, they had ongoing coaching with these hospitals. Now, the extent to which the hospitals truly embraced the culture changes can't be known. But on the other hand, if this thing is going to work, why would you expect the average hospital that isn't part of a collaborative effort to fare any better with implementation? So I think you can't keep saying, oh, but they didn't implement it right, if these hospitals couldn't achieve that. Now, I said that this talk wouldn't be a downer, so what's the story here? Well, I do think there's an upside to this, and it involves looking back at another study that came out a few years ago from the VA system in the United States. And this was a study that did involve checklists, but more intensively was looking at teamwork training. This was a study that involved control sites as well as these VA facilities that used an intensive team training program, and also included ongoing coaching and debriefing. I want to emphasize that this was a very intensive program, yet it was conducted at multiple institutions, so it was feasible. Just to show you how intense it was, in addition to 2 months of preparations and planning with each facility's implementation team, there was an on-site session that involved closing down all the operating rooms for the day. So they were really emphasizing that this was important and that people needed to go. And the principles of crew resource management that were used included having the team members be encouraged to speak up about safety risks, conducting the checklist with some pre- and post-op briefings, and then various communication strategies such as recognizing red flags, some rules of conduct for communication, stepping back to reassess the situation, situation awareness, and more effective handoffs during care transitions. And what they found was that there was a reduction in mortality over the quarters of the training program. Now, for any researchers or anyone who looks at graphs like this, you may wonder if this is just a secular trend, but actually in the control groups, they saw 50% less improvement. So this was a very nice example of a study that used contemporaneous controls and showed that the sites that participated in this teamwork collaborative showed 50% more improvement in mortality, which is obviously the most important outcome you can have after surgery. They also, I mean, it wasn't perfect. Like when they looked at the improvements specifically about communication amongst operating staff, staff awareness, overall efficiency, you know, there was improvements reported in like 30 to 50% of facilities. This was qualitative data, but it was still interesting that in addition to their concrete improvements in mortality, many of the staff did note some specific, more qualitative improvements in how the culture and the communication and the processes of the surgery was going on. So what does this have to do with checklists? Well, what we have here is a robust study that demonstrated the concrete impacts of team training on hard patient outcomes. And the intervention included checklists and debriefings, but this was not a one-off training session. The operating rooms were closed for attendance. There was intensive pre- and post-education activities. And so my overall take on this is, yes, it is true that you need some teamwork to implement the checklist as it's meant to be implemented. But that may not in itself be enough to actually improve outcomes. That's what that more recent Michigan study showed. But this study shows that if you really focus on teamwork and the checklists are part of it, fine, that is a goal that is going to improve patient outcomes. So that again, moving back to this Carl White quotation, the superficial simplicity was we started by thinking that checklists were a simple intervention from aviation that we could easily emulate. Then we thought teamwork was required to get it right with lots of recommendations for how to implement effectively. But now the profound simplicity is that it's really about the teamwork. It's not just a means to an end. Better teamwork is not just the way to implement the checklist. The teamwork is the main event. Okay, yeah, teamwork, culture, blah, blah, blah. It's not the most exciting message. So I did thought, even though that is the most important message from this talk, I think is that really teamwork and communication are not just strategies for implementing specific interventions. They really are where we need to go in healthcare. I did think, in the interest of keeping it a little bit more exciting, I thought I'd tell you about something that's going on the horizon that I think is pretty exciting. This was a paper from the UK that the journal that I edit, BMJ Quality and Safety, was happy to publish. And there's a lot of work going on with early warning scores in pediatrics. So even though this wasn't a pediatric study, I thought I would include it. So this was a study at 2 hospitals in the UK. I also like the fact that this was from the UK, not the US, because it's easy to have sort of tech envy about some of the things that go on in the US, but I don't think anyone could be envious of the state of hospitals in the UK. It's probably a lot more like Canada. So these hospitals nonetheless managed to pull this off, where they had a wireless handheld computing device transmitting early warning scores to wireless tablets and computers at one of the hospitals, but just to the desktops on the wards at the other hospital. Now, both hospitals did have a paper-based early warning system in place for years and a rapid response team well established for years at both hospitals. Now, this is a very busy slide, and I'm not expecting anyone to look at it in detail, but for those of you who don't know what an early warning score is, this is what it looks like. I'm not really sure why they haven't taken off as much in North America as they have in the UK and Australia, but again, in pediatrics, there is a lot of interest in this right now, and actually a colleague of mine at Sick Kids, and a colleague of Trey's actually, Trey Coffey's Chris Parsham, is running a trial in the US and Canada looking at a pediatric early warning score, and I believe there's another trial going on with another group. But the basic idea with this early warning score is that it looks a little bit like the types of vital sign sheets that you see in intensive care units, but it's for regular patients on the wards, and it basically, for all the possible vital signs or things that you would want to monitor, if you're either too high or too low, you get a number, and if the number of the score gets higher, you're supposed to either take the vital signs more often, or if it gets higher, you're supposed to contact the doctor right away, and if it's really high, you're maybe supposed to just call the rapid response team. What the bedside wireless system looked like is it literally was a PDA, and I've just shown an example of this. I mean, it looks a little funny now because we're all used to just doing things on our phone, but I believe these were dedicated PDAs for this study, and you enter the patient's pulse, let's say, you store the pulse, and then you see after you've done the other vital signs what all of their scores are, and then you're ready to submit the observed results, and it'll get transmitted to the electronic health record basically, and alert the clinician if it's a worrisome number. And the sort of money shot for this study is this graph. It looks like a statistical process control chart. For those of you who do any kind of quality improvement work, you'll have seen charts like this. On the vertical axis, they have the mortality rate. It's called the seasonally adjusted mortality rate because, as we know, there are different conditions that are more prominent and have higher mortality at different times of year, especially respiratory illnesses. And then the black dots are actually how well the system, this early warning system, was being used. And what I like about this figure and why it's such a nice illustration of why this type of approach in quality improvement work can work so well is the white circles, the mortality, you can see that they're bouncing around before the intervention takes place. And then around November 8th or March 9th, there's a consistent trend where the numbers are below the mean, which is what's called special cause variation. So instead of bouncing around and having roughly equal proportions of the mortality rate being above the average of 7% or below, now you can see there's been a shift, or again, what's called special cause or non-random variation. And now more of the points are below the mean. In a sense, there's a new average. But what's really nice is because they've shown the black squares as well, you can see that early on, and this is where you need to use the right-hand vertical axis, you can see that they were having a low number of observations at first. Like you'd expect that anytime you're implementing some new tech thing, it's not going to get used appropriately right away. And so at first they were never higher than about 1,000 observations per month. But then between about November 8th and November 2008 and between July 2009 and November 2009, it really starts to shoot up. And at the time that those black dots shoot up and they're achieving really high rates of use, that's when the mortality goes down. So that's a very compelling evidence that not only did mortality go down, the hollow circles show that, but it happened at the same time that the intervention started to really take off. And the other hospital had a very similar pattern. Again, you can see that the open circles start to dip down and stay down below the mean in around July 2008, and that was around the time that the intervention really took off, where the dark square boxes are reaching their high levels and being used consistently. So the authors reported that the crude mortality fell from a baseline of 7.75% to 6.4% in one hospital for an estimated almost 400 fewer deaths, and at the other hospital, similar results. And these were unrelated hospitals. That was another strength of this paper. They prevented about 370 deaths. So this is pretty spectacular. There's not many interventions in any field that saves lives, never mind in safety or quality. 2 hospitals implemented a system, not a particularly fancy one either, and both showed clear signals of reduced mortality that coincided with the ramp-up of the electronically transmitted vitals. The main caveat is that both hospitals already had experience with using early warning scars and a rapid response team. And David Bates, who many of you may have heard his name from Brigham and Women's Hospital in Boston, has been a champion of computerized order entry and many other aspects of patient safety, and a colleague of his who works at the Brigham and also in Israel wrote an editorial about this paper in which they refer to this technology as the next major opportunity to improve patient safety, or the next big frontier. Really, there's the possibility of combining information from not just vital signs, but also increasingly lab values or other information available, even in only a partially electronic record, is really phenomenal. So that, for instance, if you have a drop in blood pressure and an increase in pulse, with the decrease in urine output, that's already, more concerning than just a fall in blood pressure alone. It suggests maybe impending sepsis. And then the extra improvement is when you combine that with different types of data, such as lab results or admission diagnoses, you can see that this decrease in blood pressure and increase in pulse is occurring in a patient who's just had a positive urine culture or just been admitted for surgery. That obviously suggests an imminent, surgical site infection going on to sepsis. So I really do think this is an exciting technology and probably will be an active area of improvement over the next 5 to 10 years. So I'm just going to wrap up, though, overall, except for that sort of exciting horizon, I would say that there's been, in the last 15 years, lots of effort on specific safety targets without addressing communication, teamwork, or culture. And now we're starting to see some strategies that combine concrete interventions with teamwork and communication, such as handoffs, and I know Trey will be speaking about that, as well as the central line bundle and maybe the surgical checklist. But it's hard, and this is the profound simplicity that Carl White talked about, it's hard to avoid the conclusion that culture is key, and the rest is mostly rearranging deck chairs on the Titanic. And realistically, I mean, it's nice to think that we can just prevent some central line infections and VTE, prophylaxis, have a few order sets here and there, but really if we want to make any important gains, I think we really are back at the place that we initially thought we needed to be, which is that teamwork, communication, and culture are key, and that they are the main event. They're not just the means to the end. And with that, I'll say thanks very much, and I'm happy to take any questions before turning things over to Trey.
All right, thank you, Dr. Shorjania. It was a great introduction to this topic. And for those of you who might have a question, please do type it in as quickly as possible, because Dr. Shorjania has that sometimes inconvenience of having actual patients to see, and he may not be able to stay for the question period at the end. So now is your chance to get a question in while we wait for Dr. Coffey to get prepared. If there's any questions for Dr. Shorjania, we'll give you just a second or two to type some in. And also my chance to remind the audience, type them in as you think of them, then we don't have to, then we have them ready when we do call for these questions. So, all right, so we'll move on. Hopefully, Dr. Shorjania, you can stay for a little bit at the end, but if you can't, of course, you do have to leave, then that's perfectly fine. And thanks thanks for your presentation so far, if you're not here when we thank you at the end. All right, over to you, Dr. Coffey.
Thanks, Doug. And I know you can see questions we can't see, so if you get one that you'd like to interject and loop back to something Kaveh was talking about, please feel free to interrupt. It's no problem. So now my goal is to give a little bit of a personal and pediatric perspective on that kind of journey that Kaveh's been talking about. And first, let me just say, I feel really lucky to be able to work here at the University of Toronto Centre for Quality Improvement and Patient Safety with Kaveh. And we have too few opportunities to come together and exchange these big picture ideas. So preparing this webinar together has been really fun and interesting for me. So to me, our title of disappointments and successes and what's next on the horizon, for me the order is a little bit different. So for me it was early on successes and that enthusiastic phase of discovering patient safety. And Kaveh talked about that as kind of the initial, perhaps oversimplified view of things, with the second act being the hard work being a bit disappointing and recognizing some of the deeper complexities of making change in this area. But I really feel more recently that some major bright spots are appearing on the horizon, so I hope to give you a sanguine view. But first, I'm really curious. I know there's folks on the line who are involved in patient safety work, and I'd be interested to know if we can get this audience response system to work. If you had to think about this question for yourself, with respect to this patient safety journey, do you feel like you're in a discovery mode? Do you feel like you're working really hard in this area but getting frustrated? Do you feel like you're working really hard but feeling really optimistic, or not sure and none of the above? And I'll give a second for answers to roll in on that.
Yeah, so for those of you who've never done a poll with us, this is your chance to provide your feedback just by simply clicking on the screen and making your choice. We'll give everyone just another few seconds to put in their response.
And if you're a none of the above, I realize I have no idea what that means to you, so please feel free to type in comments about if you're in the none of the above, what are your thoughts on this?
Yeah, if you want to put in something to put yourself in that none of the above category, just type it into the question box, and I'll certainly bring that to the conversation as well. So I think we've got all the responses in, and it looks like 41% are working really hard and getting frustrated, and 43% are working really hard and feeling optimistic. Only 13% find themselves in the discovery phase.
Okay, that's really interesting. It's kind of fascinating that we're evenly split between the working hard, getting frustrated, and working hard and feeling optimistic. So I'm not sure if the frustrated people have something to say to help the optimistic people appreciate more how hard it is, or whether the optimistic people have something to say to give their frustrated colleagues a bit of hope, but hopefully a little bit of both. So thank you for that. So for me, I'm going to take it back to this journey in 3 acts and where it kind of began for me. And I was a resident before cell phones had cameras, so there's actually not a picture of me as a resident, but I looked sort of like this. I looked pretty confident. I had come out of a good med school, and I had kind of the trappings of a confident professional doctor with the white coat, and I had the physical tools of communication with the pager and the phone. But what I didn't realize was that I was actually really ill-prepared. I didn't actually have the real communication tools. And so those first nights on call, when I got calls from nurses, I often really couldn't decode what they were looking for. I wasn't sure if it was just for information or whether they wanted me to act on what they were telling me. And I had a general sense they were really dissatisfied with my responses, but I really couldn't figure out why. And that was pretty painful, but kind of an everyday thing that I sort of got used to. But there were more significant communication and culture problems too. And a little further in my R1 year, I was in the position of being responsible for an oncology patient who was very, very sick. And an event happened to me that's probably pretty similar to events that many of you might have heard about in your organizations, which is that as the child became sicker, there was that tipping point between compensated and uncompensated shock. And I was not experienced enough to realize in time how in over my head I was. And then when we tried to activate help, we have these chain of command issues where if you couldn't get the next person in the chain of command to agree to asking for help, you couldn't go around that to ask for help. So there were some major culture problems there. But when that event happened to me, we didn't have any language. There was no debrief. There was no name put to the event. You just kind of had to park it like a bezoar of shame and confusion and self-blame. So it was really a relief to me when years later I started to discover that there was this thing called patient safety and that this problem went way beyond me. So we saw, as Kaveh mentioned, it's about 15 years ago that it sort of came into the popular consciousness that we have this ubiquitous problem of harm in hospitals. And there were studies going on around the world with results that varied, probably more for methodologic reasons than actual differences in safety. But suffice it to say, we are all able to say, we're not alone in this. This is a big problem, and we now have a language and perhaps some possible solutions. And so that, for me, was the discovery phase and a really exciting time. In fact, it was almost too exciting. There was too much candy in the candy store. There were opportunities to learn patient safety, and when you learn something that's fairly new, 5 minutes later you are obligated to begin teaching it to everyone else. So there was plenty to do there. There was an opportunity to lead the implementation of medication reconciliation. There was the opportunity to take rounds out of the conference room and do them in a family-centered way that should increase patient safety because you're actually seeing the patients. There was a lot of opportunity to advocate that everybody do lots of safety reporting and morbidity and mortality reporting. And then also there was the competing domains of quality. So Kaveh alluded to the fact that, we have efficiency and we have patient-centeredness and we have clinical effectiveness all kind of competing for attention. And my observation was that efficiency projects really started to grab my attention and others. They tended to be funded and they tended to be quicker wins. As I was realizing that safety was a tougher nut to crack than I thought, there was low-hanging fruit in the efficiency area, and that really distracted my attention from safety. And around this time, a colleague and mentor of mine, Ann Matlow, was leading a group all over Canada, and this was done with big support from CAPC and from the Canadian Patient Safety Institute and others, to try to quantify the problem of harm in hospitals to children in Canada. So we had this huge mountain of adult data, but we actually weren't really sure that we fully understood the burden of the problem in pediatrics. So she led this multi-site project where we pulled charts randomly from geographic nodes across Canada, and in a really thoughtful design did so with good representation of the community hospitals, reflecting the large portion of pediatric care that occurs in community hospitals in our country. And I believe this remains to be the only national pediatric medical error epidemiology study. And here I'm curious again about the audience's awareness of these results. This study has been out for a couple of years, but it might have come out during a low phase in the patient safety hype cycle. And so we wonder how well people know these results. So I'm curious, amongst folks that are with us today, if you had to answer the question of out of 100 kids admitted to hospital in Canada, how many of them experience harm that's preventable? And so this is significant harm, not really trivial stuff. And preventable is sometimes hard to say, but at least most likely preventable. Is it like 1 out of 1,000, 1 out of 100? You recall that adult data? Is it more like 7%?
So once again, just click on the screen to make your selection. I think we've got most of the responses are in. We'll give everyone just another second or two. All right, we'll close this one off, and the majority of the audience is saying 7% of admissions, at 52% of the audience saying 7% of admissions, and 33% of the audience is saying 3.5% of admissions, 10% saying 1% of admissions, and only 5% saying 0.1% of admissions.
Okay, that is really interesting. So I think what that tells me is that this audience is not in a position of underestimating the burden of preventable harm in kids. So what we found is that the overall percentage of kids experiencing an adverse event, and that's defined as harm that's not from their underlying disease, but not necessarily from a medical error, was close to 10%, and so similar to that Canadian adverse event study done in adults. And we found that about a third of those were at least probably preventable. So it is between 3 and 4% overall. And we did find that the rate was a little bit higher in the academic centers, probably not a surprise to people who work in a tertiary care environment. Just the magnitude of risk that kids are subjected to is probably higher. And we found the pattern was a little different, with surgical adverse events predominating. And the rate was a little bit lower in community hospitals, and we found that diagnostic errors predominated. Again, it's probably not a surprise and probably resonates with what people would predict. So a little bit of time after this paper came out, I assumed the role of patient safety officer at Sick Kids. And that is when this question of whether we were getting anywhere on patient safety became front and center for me. Because until I had direct responsibility, it was okay for me to jump from project to project in my over-enthusiastic way. And it was maybe it was somebody else's problem to know whether we were really moving the dot overall. But I suddenly felt like that was my problem, and I felt like I really couldn't answer the question as to whether my organization was getting safer or not. And then meanwhile, we had sobering evidence coming from the academic world showing that perhaps the number of adverse events that we originally thought with the 100,000 lives and the Institute of Medicine report, that actually that was maybe an underestimate, and it was actually maybe worse than we thought. And there was a little bit of longitudinal evidence coming out of different populations showing that these rates were pretty static, and so we weren't really making big gains in fixing this problem. And my observations as more of an operational person were really similar to what Kaveh described, which is that there were an abundance of promising tactical interventions out there, but they weren't necessarily scalable, they weren't necessarily transferable from one place to the next and spreadable. And then there was this problem that I call the whack-a-mole problem, which is that, you know, these interventions are hard work. So if you pull resources to work really hard on an intervention to fix one kind of safety problem, probably you're taking attention away from another safety problem, and your overall net gain is neutral. So with that slightly depressing Act 2, I want to move on to the more optimistic Act 3 and talk about a few things that I feel suggest that the horizon for pediatric patient safety is quite bright. And I'm going to start with a paper that reviewed trends in hospital-acquired infections. I'm going to say this is a goodish news story because we're moving over to a philosophy that if something's potentially preventable, that the only real goal is zero, and we haven't hit zero on these things, but there's really been a huge amount of progress. And so this paper was a very large cohort study with a huge amount of patient data looking at 3 kinds of healthcare-acquired infections: the central line-associated bloodstream infections, the ventilator-associated pneumonias, and the catheter-associated UTIs. And what it showed was that over a relatively short number of years, all of these decreased really quite substantially, with the exception of the catheter-associated UTI. And the practical implications of this, there are many. One is that these healthcare-acquired infections are very costly. They really increase length of stay and costs of care. And so this paper asserted that the reductions in CLABSI alone saved the U.S. healthcare system $131 million. And they also discussed how probably these results can be attributed to large-scale quality improvement collaboratives. For example, the huge Vermont-Oxford network. And they talked about how it's really tough to know exactly which intervention caused a result, given that there's sort of big picture secular trends at work. But I think their conclusion, and I would agree, was that conscious, focused, organization level and collaborative improvement was succeeding. And next I want to talk about the question that Kaveh alluded to, which is that, it may be that we're finally getting somewhere with this really complex teamwork and communication problem. And I'm just going to use the tale of the IPAS handoff to give an example of that. So why focus on teamwork and communication? I think all the folks on the line who've had any kind of patient safety 101 type training are very well aware that communication failure is the most common root cause of really serious safety events. And where it's not the primary cause, it's often a primary cause in the vast majority of events. And this was realized by a group at Boston Children's Hospital along with the story of resident duty hour reform kind of taking off and more awareness that fatigue was causing patient safety problems, but by limiting duty hours we were causing more handoffs, and they decided to try to tackle this handoff problem using a bundled approach. So their thought was that if they could give residents a bit of basic teamwork and communication training plus a verbal mnemonic and a computerized handoff tool, that bundled approach may work. And so they tried this out in a single center pre-post fashion and got a really promising result. Not a definitive result, but a result that was compelling enough to convince a big group of us to try to do this in a multi-site fashion. So the objectives of the big IPAS study were to figure out if this bundle was associated first and foremost with the hard patient outcome of overall errors and preventable adverse events. We also set out to determine whether handoff actually improved, and we kind of considered that a process measure. And then we needed to look at the balancing measure of impact on workflow, because clearly a process that was going to take busy residents more time would be a no-go. So for those of you who are unfamiliar with the IPAS mnemonic, I'll do a quick run through. We really were aiming for structured common sense here and something that would feel to people like kind of what they do anyway, but with a little bit of enhancements with a safety lens. So we start with illness severity, really cueing the listener on how sick this patient is relative to the whole list, a concise, up-to-date patient summary, an action list that has really specific timelines, and then situational awareness and contingency planning, which is thinking ahead to what could go wrong and beginning to articulate a plan for the person on call if that event arises. And lastly, synthesis, which is a closed-loop communication technique just to ensure that critical information was actually heard by the receiver as intended by the giver. When we rolled this up from the pilot study to the multi-site study, we added a few components, really important components we think, which was to invest a lot in faculty development prior to the go-live, and then to bring in a regime of observation and feedback during a period after the go-live. And this really maps nicely to calls from the ACGME and the Royal College to really bring handoff training and observation and feedback into our competency-based medical education work. So a quick review of some of our results. This looks at the percentage of verbal handoffs which we tape recorded that had key elements present. You can see they all increased statistically significantly. However, none of them reached 100%, and the degree of increase was a bit variable. In terms of the written handoff, which we scanned and analyzed, all of the components also increased significantly and to variable degrees. But most importantly was this, and that was that the rate of preventable adverse events decreased across most of the sites and the cohort overall. And this looks like small numbers, but when you multiply these percentages over this large number of kids, there really were a handful of kids we feel were spared significant harm as a result of this intervention. And we feel that this was kind of a large and somewhat even surprising effect size for a patient safety intervention. And you can see that the non-preventable adverse events didn't change. In terms of workflow, there really were no changes. Residents spent the same amount of time in handoff and roughly the same amount of time in all their other activities. So this is not a randomized controlled trial. This is a multi-site pre-post, and so we really are limited to say definitively that the handoff intervention was causal in the results, but we did see the parallel improvements between the process and the outcome, and we did find that the findings were reproduced over multiple sites, so it really does seem promising. As we work to spread this across other disciplines, we do recognize it is challenging to take something that was designed in general pediatrics and extrapolate it over the rest of our hospitals and universities. And this is really what I call low-tech, high-touch work. So you really have to invest time and sweat equity and attention in launching this work. And so feasibility and sustainability require, I think, careful consideration. In terms of what we're doing with this in Canada, we have conducted a needs assessment of Canadian PEDS programs. This was led by my colleague Zia Bismillah, which showed that very few programs had any kind of formal approach to handoff in place. Most were interested in doing a national rollout of IPASS, and many were interested in linking this to some more scholarly work in this area. So Zia and colleagues from these institutions have put forth a couple of grant proposals, and we're calling it by the shorthand IPASS Canada, so please stay tuned for that. Okay, now I want to switch gears a bit and talk about what I think is the brightest spot on the pediatric patient safety horizon. And this is a model for collaborative patient safety improvement led by a group in the United States called Solutions for Patient Safety. And they really have a mission to eliminate serious harm across all children's hospitals. So when I talk about this with folks, I like to just give a little bit of the history of how they evolved. I think it kind of helps understand how this has come to be. So about 5 years ago, the chief executives of 8 children's hospitals in Ohio got together and formed this network. And believe it or not, the children's hospitals in Ohio are viciously competitive with each other. Some of them are actually across the street from each other. And they have really like 100% market share for pediatric care in the states, in that state. But they decided that they didn't want to compete just on safety because they felt that that was immoral, and they felt they needed to get as far as they could, as fast as they could on safety, and they would do it that better by doing it together. So in relatively short order, they made huge gains in surgical site infections and adverse drug events and saved thousands of children from harm and avoided millions of unnecessary healthcare costs. So they have this philosophy of all teach and all learn, and what this means is that if you adopt standard definitions and you commit to really clear prevention bundles with auditing of compliance of the bundles and analysis to which part of the bundles are working and not working, you really leverage a huge amount of amazing data, but then you're also leveraging those other sort of person-to-person connections that need to be made to help people navigate the pragmatics of doing this work. And so by being really transparent, they can show, well, this hospital is doing the best on this one, so now they're obliged to teach everyone else what they're doing, and vice versa. So this really caught on at the time that Obama was passing the Affordable Care for All Act. There was a recognition with the federal government in the U.S. that these health care acquired conditions, things like central line infections, were really costing the system a lot of money. And so they started giving out contracts to hospital groups to do this work together to eliminate these hospital-acquired infections or hospital-acquired conditions. And so they gave a big grant to the Ohio group to launch a national group, and that became known as Solutions for Patient Safety. And in pretty short order, they had recruited a bunch more hospitals, such that now they've got almost 90 hospitals. And with us at Sick Kids having just joined, they've now got their first international hospital. An interesting thing that's been going on in parallel with this is that although the model focuses on these healthcare-acquired conditions that are very measurable and very detectable, they don't rely on adverse event reporting, so they're very reliable sources of data. A subset of them decided to also take on culture work. So going back to what Kaveh said about doing this stuff without embedding it in a wholesale, deep approach to patient safety culture, many of the hospitals really launched some work in that, and I could talk a little bit more about what that is. But our friends at Cincinnati published their results doing this culture work and committing to tracking their rate of serious safety events, and showed that with this multifactorial culture approach that they describe nicely in the paper, they were able to reduce their serious safety events by 2/3. And since then, a few other hospitals have shared their serious safety event data more informally, showing that what we thought was maybe just a special, unique thing from our friends at Cincinnati that couldn't be replicated anywhere else, we're now coming to the conclusion that it can be replicated elsewhere. And so very recently, Solutions for Patient Safety have begun to start sharing their results. It used to be that you could only sort of hear it at a talk, but it wasn't publicly available. But now they've got it all on their website. And I think this website's really cool. And I'm just going to navigate away from the PowerPoint for a second to show you what can be found on this website. So they now have this results tab that brings up a series of run charts or statistical process control charts for all the healthcare acquired conditions that they're working on collaboratively. And so these are just continually updated every month as hospitals submit more and more data. So zeroing in, for example, on falls, and I'll make that a little bigger, falls represents an area, or falls with serious harm, where they have virtually eliminated the problem. In other areas, they're just beginning to get a handle on the problem, and they're doing what they call pioneer and discovery work. So for example, readmissions, which is something that's very controversial in terms of is it preventable and is it really a safety issue, they've been able to carve out a subset of readmissions that are felt to be preventable, and they're just beginning to show statistically significant reductions in those readmissions. So there's a wealth of other information about Solutions for Patient Safety on this website, and I know lots of folks across Canada are curious about this work, so I would really encourage you to visit there and take a look. Okay, so just my concluding thoughts is that we really are getting somewhere on patient safety, and it is harder than we thought, and that's kind of the point. We are now realizing the complexities that we needed to realize, and we are poised to move into the next phase. I really think it's a promising horizon, and I think the two big areas that show promise for this phase are collaborative improvement and a greater emphasis on safety culture. A few resources. I was encouraged by CAFC to do some cross-promotion with our colleagues at the Canadian Patient Safety Institute, and let you know that there will be a Researcher in the Room webinar where Anne and I will talk about the Canadian Pediatric Adverse Event Study and the IPAS study and some other work in more detail coming up on June 23rd. Of course, you have the CAFC Patient Safety Collaborative and the Knowledge Exchange Network. There's a website I would love to point people to called ps.net, where there's really expertly curated quality and safety content. There is Pipsqueak, which brings sort of an international conversation on pediatric patient safety. All of the IPAS handoff materials are available free and open access via this IPAS website. Sorry, I just noticed there's a typo. It's ipashandoffstudy.com. And then I mentioned the SPS website. And then lastly, as some of you will know, I was live tweeting the first half of the talk, and there's just tons of really great people talking about patient safety on Twitter, and it's really a neat forum. So for any of you who are interested, give a shout out to myself and Kaveh. And with that, I really am interested to hear your thoughts and questions.
All right. Thank you for, once again, a fantastic presentation, and really, I mean, it's a lot of information because it has been a long journey for the last 15 years and a little bit of a downer at times, but you certainly did show some real bright spots that we can look forward to, so really fantastic. Just to go back to the first poll question that we asked about the phase of your journey, Alan did want to point out that he was one of the none of the above who said he was working really hard and frustrated, but still had hope. He's still optimistic. So frustrated and optimistic is possible. So
that sounds very healthy and normal.
The first question that came in was from Maureen regarding the IPAS piece. She was just asking, with IPAS, how have pediatric surgical residents or trainees been involved in Canada?
That's a great question. I wouldn't say that there, to my knowledge, is a systematic approach across Canada with surgery, but I will speak to a few things that are going on in the States and in Canada with surgical groups. So one thing we've learned with working with our surgical colleagues is that their time pressures are different than our time pressures with with respect to expectations of time spent per patient on handoff. And so while it might be a norm in general pediatrics to spend 2.5 minutes per patient, it is not a norm in safety to spend 2.5 minutes per patient. And so one resource that we have is we're now launching a project with the Society of Hospital Medicine supporting and mentoring IPASS implementations across North America. And many people are doing organization-wide implementations incorporating their surgical colleagues. And one small addition we've made to our armamentarium is a video that shows a surgical-style IPASS handoff, and it illustrates the point that it's a simple framework and you can actually do an extremely quick, fast IPASS, but full IPASS handoff. And I think that's going to be more appealing to surgeons than looking at curricula that are more created with medical folks in mind. And I can speak a little bit at my own hospital to what some of our surgical teams are doing. Some of them are looking at different platforms for the written tool. For some groups, it really fits with their workflow to have an electronic health record-based paper tool that prints out. For others, they are really small teams with really high turnover patients, and they really need a mobile application. And so while we don't have a perfect mobile application yet, I think there's a lot of great work and conversation going on in that area, and that's going to be something that's going to allow bringing our surgical colleagues into this more.
All right, thank you. The next question just came in from Lori. She's asking, how are you linking this work with Accreditation Canada and standards for patient safety?
That's a really good question. I think that a lot of our work aligns, but occasionally things can compete. And so, for example, our work with medication reconciliation. So I feel very attached to medication reconciliation, and I have been and continue to be someone who spends a lot of time advocating for medication reconciliation. Saying that, as I look at safety events at my hospital, it doesn't feel like, you know, where the big money is in terms of preventable adverse events in pediatrics. So we need to attend to our obligations with accreditation, and similarly with our provincial quality group who mandates that we publicly report our MedRec data. We need to do that work, but we need to also balance it with other data that suggests the money in terms of preventing harm to kids, there's more of it elsewhere. So that's really it's really a challenge. You know, saying that, we weren't getting anywhere with MedRec until accreditation made it a requirement. So making it a requirement was a giant leap forward for us in terms of getting executive support to do the work. So it's a bit of a mixed bag.
Diane Aubin from the Canadian Patient Safety Institute just gave us a link to that so that folks can register for that webinar that's going to feature Dr. Coffey and Dr. Ann Matlow. So you can go to the Patient Safety Institute's website and register for that. We had another question from Maureen, who's asking if you can comment on why a pediatric patient safety collaborative, and what. Sorry, let me just try that again. Can you talk about why a pediatric safety collaborative can do, or what a pediatric safety collaborative can do that is different than a combined adult and child collaborative?
That's a great question. And I've had variations on that question as I've spoken to different leaders and bodies about this work. So a couple things. One is that we, in pediatrics, although the overall magnitude and burden of preventable harm is similar to adults, and although many of the root causes are similar, I mean, the communication problem is quite similar across all disciplines. The nature of some of our events is different. And so, for example, the profile of pediatric medication safety errors is, or medication safety problems is different than in adults. Another example is that all of those healthcare-acquired conditions that I alluded to with the Solutions for Patient Safety work require pediatric-specific bundles, because some of the elements in the adult bundles actually don't apply to pediatrics. There's actually good evidence that some of those bundle elements that are so effective in adults have a different effect in pediatrics. So I think we need to have pediatric-specific recommendations as to what to do. And I think we also need to be able to compare, like with like. So when I'm talking to folks in the SPS group, similarly to folks who are in, the CAF-C group, who I know have are dealing with similar realities as we are, it's much easier for me personally and also for all the folks around me at the organization, all the decision makers and administrators and leaders who are dealing with, pediatric tertiary care. What another pediatric tertiary care center has to say and what they're doing carries a lot of weight. And then when we're looking for advice as to how to do the work, those are the people that we are looking to. So I really feel we do need a pediatric-specific safety collaborative.
All right. Elena has asked, she's commented, culture is a broad term and at times an overwhelming thing to tackle. How have you measured progress with shifting to a just culture and a culture of safety?
That's such a great question and really timely, because we just did, so many of you will know that with Accreditation Canada and our accreditation cycle, we administer their patient safety culture survey on a not yearly basis usually, but every 3 or 4 years. But you have the option to do mid-cycle culture surveys, and we just elected to do a mid-cycle culture survey. And a couple of years ago, when we did our last one, we identified just culture as a hotspot. So we identified that staff feared reprisal or punishment, or that their career options were limited if they were involved in a patient safety incident. And we actually made a fairly big investment in, or what we thought was a fairly big investment at the time, in bringing in a just culture expert to do a 2-day training session with 50 of our staff. And it was really, to me, it was very paradigm shifting, because what we learn in patient safety is that, we've got to get away from shame and blame, and it's all about the system, which leaves you a little bit puzzled as to what to do when you have a safety practice and staff are really busy and they're not really following it that well. Who's accountable for that? And what the Just Culture training did for me was it helped me bring that pendulum back to the right, what I feel is the right spot. It's not shame and blame, but it's not no blame, no accountability. It's fair and it's balanced. And there is an individual accountability to adhere to safety practices, but there's also an organizational accountability to ensure that those safety practices are followable and that people are crystal clear on what's being expected of them and that it's being reinforced in everyday work. So our hospital leadership has been talking about this and really deepening their understanding of this. But I've had a preview of our most recent safety culture results, and it suggests that that is not yet impacting the way people feel at the front line. So just like everything else, making an investment in just culture seemed simple, and the more work we do in it, the more we realize how much more we have to do.
All right, and I'm assuming we haven't heard from Dr. Shojania that he did have to leave us?
He did have to leave, and he really appreciated everybody's time and engagement with this.
All right. We have a question that came in from Alan who says, a big challenge that he's seen is the failure to sustain patient safety interventions after implementing them. How are you managing this, and why do you think it's working so well?
Well, I wouldn't say I'm managing that yet. I still think we have a whack-a-mole problem, and we're doing something really well, and then years later an event happens, and you're like, but I thought we fixed that, and it turns out that, in your mind, you remembered hearing that presentation that showed it had been fixed, but those people were then deployed to do other things, and then the problem resurfaced. So while for myself and our organization, it's kind of early days in this new approach to patient we're going to try to do is, for one thing, we're going to better prepare our leadership and governance folks to help us with safety, because you know, we all vary province by province in terms of what we are required to tell, you know, our province or our boards in terms of events. But in Ontario, we are required to only report critical incidents, which thankfully at a children's hospital are fairly rare. But they really are just such a tiny tip of the iceberg that it gives leaders, senior leaders, and board members maybe a bit of a false impression that this problem is minor because they're only hearing about it a couple of times a year. And so we've had the opportunity to send some executives and board members to a patient safety learning session taught by other executives and board members to sensitize them to the principles of high reliability and patient safety culture, where they need to be willing to accept the message that things are messy and that maybe we don't have everything completely under control and that maybe we need to be doing more. And I've really found that to be really favorable in terms of being able to have an open dialogue within the organization about safety problems. And I think this will put us in a position to get more leadership attention so that we can focus on all the big causes of harm simultaneously rather than kind of jumping from thing to thing. And that's my optimistic view. I hope to report back to you in 2 or 3 years that we've been really successful in getting results using this approach.
Always with the optimism. That's good. You mentioned a Just Culture training resource. Is that something that you can share?
Yeah, so the actual materials I can't share because we entered into an arrangement with a firm that we hired to come and do the training, but I will say we worked with Outcome Ingenuity, and we had a really great experience with them. They have folks who have been doing accident investigation and Just Culture training with various industries who are extremely experienced, and that's really needed. I think someone with deep, you know, career-long experience in this stuff who has kind of an answer to everything really went a long way for us. And also just having someone who's really dynamic and engaging was really an asset for us. So we were pleased with our experience with that approach.
All right. So that question came from Elena. One more time with that organization. That was.
It's Outcome Ingenuity. It's instead of ingenuity, it's Ingenuity with an E, all one word. And I think that our trainer who we had moved to another organization or may have become sort of freelance. So I don't know if that particular individual is still available to do the training, but we've seen a bunch of them at different. Oh, thank you. Yeah, we've seen a bunch of them at different conferences and stuff, and they've got a lot of really dynamic teachers.
We'll put their website up on their screen if anyone else is interested in more information on that. We do. Elaine Orbine, our President and CEO, has a question that she'd like to ask you.
Thanks, Doug. Appreciate that, Trey, and I know Kaveh has left. What a fantastic morning and presentations. A huge thanks to you both. Trey, as you know, you recently joined us at our CAFC board retreat, and we talked a lot about patient safety and CAFC's commitment. Some of the work we've done, you've shared with our delegate, with our colleagues on the webinar today. Trey, we've identified patient safety as one of our advocacy priorities, and that comes after lots for so many years being committed to patient safety and quality. Can you give us some advice as a national organization? What would be the most effective, or where the needs are to be most effective in advocating for patient safety, given that CAFC is not at the front line, providing care, practicing, but rather as a national organization supporting all of the children's hospitals and so many rehab, community centers, home care provider agencies? What role can we play in advocacy, in your opinion, to really make a difference?
Thank you so much, Elaine. That was really a pleasure to speak with your board members about this, and they had such good insights about how, when you're setting priorities, there are so many different competing things and domains of quality that are so, so important. And I thought we had a really fruitful discussion about where patient safety sits in the really big picture that CAPC looks at. I guess I would take it back to what the Solutions for Patient Safety folks feel they've learned and what they emphasize time and time again, which is that their work has really been initiated and chartered and championed and led by their chief executives. And so I think if this had originated as an idea by the federal government or by a big national body, we might have seen people signing on and not necessarily really committing to the work. But because, we talk about how culture starts at the top, because it was a necessary step that the chief had to be fully committed and on board and had to really hear about this and understand it from a like person who's a chief at another similar organization, that they feel has been a critical success factor. And what's unique about CAPC for us is that that's really the place where these leaders convene. And so I think while we probably aren't at a place where everybody feels completely ready to sign on to a collaborative of that intensity, I think over time, more people may, and as we hopefully see more results in Canada, the case will get more and more compelling, and CAPC will really be the place where those people convene and hear about that.
Okay, that's very, very helpful, Trey. Thank you. Maybe we can continue that dialogue as you've planted some great seeds.
I hope so.
Diane from Patient Safety Institute added a comment. She says at CPSI they're working with CAPC and other national partners to advocate for patient safety together through an integrated action plan for patient safety. We're stronger advocates when we collaborate. And
Diane, it's Elaine. Thank you for that, and that's something that we're planning to pursue together as well. So that's another great way for us to strengthen the advocacy and the voice.
All right. Well, I think we've just about exhausted the list of questions. So if unless there's any last-minute questions that people want to type in, I think we'll think about wrapping the session up. We'll give the audience just a second or two to see if there's anything else coming in, and I don't see anything. So perhaps on behalf of Dr. Shojanya as well, Dr. Coffey, you can give us just some final closing comments that you'd like to end the session with.
Sure. First of all, thank you all at CAPC so much for the invitation. I really had fun preparing this. It was a great chance to kind of stop and reflect and also to pick Kaveh's brain a bit. I think my parting thoughts would be what our friend from CPSI said and what Elaine talked about, which is that we do get further faster doing this work together. And so I really look forward to seeing a lot of you on the pediatric patient safety advocacy circuit.
All right. And with that, we'll close off. So thanks again to Dr. Shojanya and Dr. Coffey, and of course, thanks to our audience for joining us. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great if you can watch live, as your questions and comments, as we can see, really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on the CAN, on the page that you can see on the screen right now. The registration information will be replaced by the recording, and it usually takes a couple of days to get that information. We have a great lineup coming up for the next couple of weeks. Next week on June 3rd, we'll have a session called Physical Disabilities and Obesity in Children, Clinical Dilemmas and Research Priorities, where we will learn about the issues related to childhood obesity that might be unique or within the context of children with disabilities. And for this session, we'll be welcoming Amy McPherson and Julia Lyons from the Holland Bloorview Rehabilitation Hospital, and we'd like to thank Prolactive Bioscience for helping support that webinar. Following that, we'll have a session titled Trauma-Informed Care, Creating Physically and Emotionally Safe Environments for Children, Families, and Staff, where we will be hearing from our colleagues at the IWK Health Center in Halifax about how trauma, and by trauma they they mean anything that results from experiences that overwhelm an individual's capacity to cope, and that can result from childhood abuse, neglect, undergoing repeated medical interventions, accidents, natural disasters, etc. And they're going to share their program to adopt a systemic trauma-informed care approach and offering trauma-specific services that can help us to better serve children and youth who have experienced trauma. So some great stuff coming up in the next few weeks. So thanks again to our speakers and to the audience for joining us today, and we hope to see you back here next week. Bye, everyone.